Hi, everyone, and thanks for joining our live webinar today. My name is Drew Heinmiller. I'm the product manager for our photoacoustic line of products here at FUJIFILM VisualSonics. And today I'm happy to present Dr. Liliya Yamaleyeva, who's going to be talking about photoacoustic imaging of placental oxygenation during pathological pregnancy. A few notes just before we get started. We will be making a recording of this webinar available after the fact. All lines are muted for the duration, so if you do have a question, there's a questions panel on the side, the panel there. So please, at any time during the webinar, just write your questions in there. We'll answer those questions at the end of the session. Expect to last around 45 minutes and then have 10 or 15 minutes for questions at the end. I'd like to introduce Dr. Liliya Yamaleyeva. She's an assistant professor in the Department of Surgery and Hypertension at Vascular Research at Wake Forest. That's in Winston-Salem, North Carolina, and her laboratory is supported by the American Heart Association and NIH. She investigates contribution of various endocrine factors to the regulation of blood pressure, systemic hemodynamics, vascular development, and the fetal-maternal interface. And also uses novel imaging modalities for this kind of imaging, for placental and fetal imaging. She received her MD from Bashkir State Medical University in Russia and her MS degree in biomedical sciences research from Eastern Virginia Medical School. And she's received several awards, including the Carolyn Tum Suden Francis A. Hellebrand Professional Opportunity Award, the North American Society for the Study of Hypertension and Pregnancy Young Investigator Award, and the American Heart Association Council on the Kidney and Cardiovascular Disease New Investigator Award. And she was recently elected a fellow of the American Heart Association affiliated with the Council for High Blood Pressure Research. She's doing some really exciting work in developmental biology, and we're happy to have her here and speak to you about using photoacoustic imaging for some of this work. With that, Dr. Yamaleyeva, I'll pass it over to you.
All right. Thank you, Drew, for the introduction, and thank you everyone for tuning in. And I'm really happy to have this opportunity to present our data on the applications of photoacoustic imaging for assessment of placental oxygenation during normal and pathological pregnancy. And in this presentation, I will talk about hypertension pregnancy disorders, and the preeclampsia is one of these disorders, its prevalence and pathogenesis, and we'll show some facts about the preeclampsia. I will also show you some data on the sensitivity of photoacoustic imaging of the placenta in vivo and also in vitro. Also the assessment of regional differences in oxygenation at the feto-maternal interface, and also placental oxygenation during normal and pathological pregnancy, and I will conclude with future directions for these projects. Hypertensive pregnancy disorders remain a major health issue for women and their infants in the United States and also in the world. These disorders complicate up to 8% of all pregnancies worldwide. And preeclampsia is one of these disorders, and it's a leading cause of maternal and perinatal morbidity and mortality. And over 50,000 cases of preeclampsia-related deaths are reported every year in the world. In addition, women with history of hypertension pregnancy disorders such as preeclampsia are 7 times more likely to develop cardiovascular disease later in life. And yet, despite continuous research, we still don't know what causes preeclampsia, and there are no definite diagnostic tests, and the only treatment for this disorder is the delivery of the baby in the placenta. And the incidence of preeclampsia is on the rise, and as you can see that it has increased 25% from 1997 to 2004, and the prevalence of preeclampsia also increased. Let me just minimize that. And the prevalence of preeclampsia also increased, and primarily due to increase in the severe preeclampsia that is associated with high morbidity and mortality. And because abnormal placentation is central for the development of preeclampsia, many studies have focused on the association between abnormal placental development and the development of preeclampsia. As you can see on this image, that placenta is the interface between the mother, and this is the maternal uterus, and the fetus. And on the right panel, you can see enlarged portion of the placenta, and in the middle, there are structures so-called chorionic villi, and they contain cells that are fetal origin, the extravillous cytotrophoblasts, and they migrate into maternal arteries such as spiral arteries and remodel these arteries. So now they can be high capacitance vessels, and they can provide enough oxygen and nutrients to the fetus. And this is the major place where the oxygen and nutrient delivery is happening, and changes in this process lead to abnormal vascular remodeling, abnormal perfusion, and abnormal placental oxygenation, as we can see in preeclampsia. And preeclampsia is defined as hypertension and proteinuria, and also hypertension and one of the end organ insufficiencies, including liver insufficiency, kidney insufficiency, and thrombocytopenia. And placental hypoxia is one of the predominant mechanisms that contributes to the development of preeclampsia. And key focus of routine prenatal care is the monitoring of the pregnancies for signs and symptoms of preeclampsia and other complications of pregnancies. And placentation is tightly controlled by oxygen during pregnancy, and therefore the accurate assessment of placental oxygenation throughout pregnancy is important for the early detection of pregnancies that are at risk for preeclampsia or placental insufficiency. And photoacoustic imaging is a novel imaging modality that is currently being tested for the measurements of tumor vascularity at cancer research and for the assessment of biomaterials in bioengineering field. However, its application in the field of reproductive biology is still in very early stages. And photoacoustic imaging combines the high contrast of optical imaging and a high resolution of ultrasound. It is a non-invasive type of imaging and characterized by non-ionizing radiation. It also can register the signal together with anatomical localization and in real time. It has relatively low cost and also can be used in portable devices. And this slide was kindly provided by Drew Heinmiller from VisualSonics. And photoacoustic imaging is based on the photoacoustic effect. And as I said, it has two components, the optical and the ultrasound component. And the laser sends the signal to the tissue, and some of the signal is absorbed in the tissue and converted into heat, and that results in the thermoelastic expansion of the tissue. And in response to that, the sound waves are generated, and these can be detected by the ultrasound, and they analyze to produce the images. And the unique feature of photoacoustic imaging is that it can detect endogenous molecules such as hemoglobin. And because blood usually has high absorption than surrounding tissue, there is sufficient endogenous contrast for photoacoustic imaging to visualize hemoglobin in blood vessels. And oxygen saturation the ratio of oxygenated hemoglobin to total, which is the sum of deoxygenated and oxygenated hemoglobin. And it can be estimated by using the photoacoustic imaging due to the differences in absorption spectra between the saturated hemoglobin and detected at 850 and deoxygenated hemoglobin detected at 750. And since the measurements of placental and fetal oxygenation are important during pregnancy, the goal of our study was to establish whether photoacoustic imaging can be used to accurately determine placental oxygenation in non-invasive way and in real time. And also we wanted to determine longitudinal differences throughout pregnancy and regional differences within the placenta during normal and pathological pregnancy. And for this study, we use vivo laser, high frequency ultrasound and photoacoustic system. And I believe that there is now a newer model, new generation of this system from FUJIFILM VisualSonics. And mice are anesthetized with 1.5% of isoflurane, and they placed in this heated platform for the imaging. And heart rate is determined by the electrodes connected to the platform, and that's how we can monitor the heart rate during the imaging. And we try to keep to analyze the data only from animals that are within the within the 2 standard deviation of the heart rate. It's usually we try to keep it in mice between 380 and 430 beats per minute. And images were obtained with this laser LZ250 probe, and 3 placentas from each mouse were scanned, and we averaged the data for each animal. And I would like to also mention that all scans that I will show were performed in the 3-dimensional mode, and that allows recording of the signal from the whole placenta and gives us confidence that we are not just measuring the signal from one section of the placenta, but from the whole tissue. And first, we usually begin scanning the placenta with spectral mode that can scan the tissue from 680 to 980 nanometers. And during that scan, we look for any artifacts of the signal, also the signal intensity, and we can adjust these parameters. And also we usually save the parameters to make sure that we are consistent between the animals. We then go on to use this oxyhemo mode, which allows us to calculate the oxygen saturation. And we can do it, as I already mentioned, in 3-dimensional mode. And this is the rendering of the placenta that was done with the program from the vivo laser instrument. And in this study, first, we wanted to look at the sensitivity of these measurements in the mouse, of using the photoacoustic imaging in the mouse blood in our hands. And on the left, you can see the probe that has 2 components. This is the laser component, and this is the ultrasound component. And for this in vitro study, we use a phantom that is composed of non-ionized water, agar, and intralipid, and we generated channels in this phantom where we would then later inject the blood. And we first generated different samples of blood with different concentrations of oxygen by using nitrogen. And we exposed the blood to nitrogen for 5, 10, and 15 minutes. And as you can see, this is the signals of the photoacoustic imaging of the blood, and these are corresponding spectra. And this is is just a representative image. And then after we generated the samples, they were either injected into the phantom to do the photoacoustic imaging, or we injected them into blood gas analyzer to do the direct measurements of the oxygen saturation. And we found direct correlation between the oxygen saturation detected by the photoacoustic imaging and by blood gas analyzer, suggesting that photoacoustic imaging is sensitive, linear, and accurate method for the detection of oxygen saturation in mouse blood. And I know that similar studies were done by the VisualSonics, but we just wanted to show this in our hands. And then we wanted to look at the sensitivity of photoacoustic imaging in vivo. And we did this by changing the fraction of inhaled oxygen, of maternal oxygen, from 100% to 20%, and each condition lasting for 10 minutes. And then we analyzed the SO2 level in the placental regions, such as labyrinth, which is the place where the major exchange of oxygen occurs in the mouse, and this is a part of the fetal placenta, and also in the maternal placenta that consists of junctional zone and decidual region. And as you can see in this image on the right, when the maternal oxygen was changed from 100% to 20%, there was reduction in the signal in both regions, in the labyrinth and also in the maternal placental region. And the assessment and the calculation, the statistics of these imaging are shown here on the left. And this data suggests that photoacoustic imaging is sensitive to measure oxygen saturation in vivo, and also that we can detect differences in oxygen saturation in association with anatomic regions of the placenta. And our data is in agreement with this recent study published by published in PLOS One journal in January of last year. And as you can see that in this study, they also changed the maternal inhaled oxygen from 100% to 5%, and they saw reduction in the signal in labyrinth and the thrombospongium region, and their values for oxygen saturation were very close to what we found. And we were glad to see that others can also show similar values as what we are finding, give us some confidence in our work. And next, we wanted to look at the placental oxygenation during hypertensive pregnancy. And since nitric oxide deficiency is associated with placental hypoxia, we chronically treated C57 black 6 mice with nitric oxide inhibitor L-NAME, starting from day 11 of pregnancy through day 18. And we measured their blood pressure, and these were measured by tail cuff, and also maternal and fetal weights. And as you can see that at day 14 and also day 18, these animals have higher blood pressure, and that was associated with the lower maternal weight and fetal weight at both 14 and 18 day of gestation. So we were able to replicate the characteristics of the model that was shown previously by others. And then we tested the ability of photoacoustic imaging to detect the placental oxygen saturation throughout pregnancy at days 10, 12, 14, and 18 in control and the hypertensive L-NAME treated animals. And we found no differences in the untreated black 6 mice, suggesting that oxygen saturation levels were stable throughout normal gestation in mice, and this shown in the solid line. And however, L-NAME infusion decreased placental oxygen saturation at day 14 and 18. And this data show that photoacoustic imaging can be used throughout pregnancies to look at the changes in oxygen saturation, and also it's possible to detect differences in oxygen saturation during pathological pregnancy and compare that to normal pregnancy. And again, all of these studies were done in three-dimensional mode. And then we looked in the same animals, but at the regional distribution of oxygen saturation in the placenta. The data on the previous slide was shown just the total overall oxygen saturation in the placenta, and this is the regional distribution. And we can also see and appreciate that, again, there are regional differences at day 14, and there is a lower oxygen saturation at day 14 in both regions in the fetal and also in the maternal region of the placenta. And interestingly, at day 18 of gestation, close to the end of the gestation, we did not see regional differences, suggesting that more pronounced changes in the labyrinth in the fetal placenta probably occurs at this time point in the hypertensive pregnancy. Hypoxia, measured by immunohistochemical markers. We stain the placentas of L-name and control mice with one of the markers of hypoxia, hypoxia-inducible factor 1 alpha, and we found that the expression of that marker was higher in the L-name treated animals compared to control, in association with lower oxygen saturation levels that we found in the placentas of L-name animals. And in our lab, we have another model of placental insufficiency and fetal growth restriction. And we wanted to use it also to look at the oxygen saturation in the placenta. And this model is the angiotensin converting enzyme 2 knockout mouse. ACE2 is the enzyme that generate angiotensin 1 to 7 from angiotensin 2. So when you don't have ACE2, you have high levels of angiotensin 2. So basically, this is the model with high overexpression angiotensin 2. And these animals, at the end of pregnancy, develop maternal weight restriction and also fetal growth restriction. We also found that the fetal to placental weight ratio as a marker of placental insufficiency was lower in these animals, and the systolic blood pressure was slightly higher but did not reach hypertensive levels. And we previously shown that these animals indeed have uteroplacental dysfunction, and not just in the uterine artery or changes in the umbilical artery hemodynamics, but also we stained placentas from these animals with 2 markers of hypoxia, and we found that both of them were increased, suggesting the existence of placental hypoxia in these knockout animals with placental insufficiency. So we use this model to measure the levels of oxygen saturation using the photoacoustic imaging. And indeed, we found that in addition to increase in the markers of hypoxia in the placenta, we found that the oxygen saturation levels were lower in these mice in the placental labyrinth and also in the maternal placenta. And we also begin to look at the fetal oxygenation in these animals. And again, I wanted to show you all the regions that we can look at the fetus and in the placenta, and we can clearly see it with the ultrasound. And we looked at the total fetal oxygenation in normal and the animals that were treated with LNAME, and we found no changes in the total fetal oxygen saturation. And now we are looking at different fetal organs to establish whether hypertensive pregnancy has an effect on organ-specific oxygenation. And finally, we also begin to assess the safety of photoacoustic imaging. And these data show no differences in fetal weight or placental weight or fetal to placental weight ratio between scanned and not scanned placentas. And this is, of course, just to suggest that there's no gross anatomical changes in response to photoacoustic imaging in this mice. But we are now continuing to look at more closely at the tissues and doing immunostaining for different markers to see whether any pathological changes are present in the placentas that were scanned using this photoacoustic imaging. And these animals were scanned at least 3 times during the pregnancy. So in conclusion, our data suggests that photoacoustic imaging can detect differences in oxygen saturation between fetal maternal regions of the placenta. And also we can find differences between the pathological pregnancy and pregnancies associated with hypertension and placental insufficiency compared to normal pregnancies, suggesting that photoacoustic imaging promises non-invasive and real-time accurate assessment of placental and fetal oxygenation. And why is this important in clinic? Because the ability to determine changes in placental oxygenation throughout pregnancy non-invasively could help us to find and detect the pregnancies that are maybe at risk for pregnancy complications such as preeclampsia and placental insufficiency. And placental and the photoacoustic imaging can also be used during fetal surgery to follow changes in placental vasculature. And this is an example from one of the publications that was published in 2015. And in this study, what the authors did, they used, this is a human placenta, and this is ex vivo imaging of the placenta. But I felt that this was the one of the first and maybe the only paper that looked at the human placenta and scanning it using the photoacoustic imaging. And here they use the needle as a surrogate for the fetoscope. And under the gel pad, there's a placenta. And by doing this, by scanning placenta this way, they were able to detect the vessels that are superficially located in the placenta, and also they could clearly see the tip surrogate fetoscope, the needle signal. So that study suggests that it can be used during the photoacoustic imaging can be used also during the fetal surgery. And this, the authors suggest that during the twin-to-twin transfusion syndrome, during surgery, you need to use the laser photocoagulation of the vessels. You can follow vessels during this time with photoacoustic imaging, so you can see them and visualize them better. Well, the future direction focus on optimizing the imaging depth for photoacoustic imaging, because that's the major limitation at this point. In the study that I showed you, this is the system is specifically designed to use in rodents, and the images that we obtained, the depth was up to 2 centimeters. Mostly we are imaging around 11 or 13 millimeters. And the human placenta, of course, is much larger. And however, in the early pregnancy, when placenta is smaller, it's probably like at the beginning of the second trimester. Even the current systems could probably be used already to detect the oxygen saturation. What we can also do to increase the depth, to use some contrast agents such as nanoparticles. Nanoparticles are also could be used to perform the molecular imaging and to target to particular molecular pathways, depending on what we are looking in the hypoxia or inflammation or any other related pathways. And of course, the laser safety is very important, and any new technique that is being introduced in obstetric and gynecology field is need to be the safety need to be is the utmost priority when any new technique is introduced, and we need to look at the possible effects of the laser photoacoustic imaging on the fetus and also on the mother. And I would like to thank my lab and my collaborators for their contribution to this study and my funding, and thank you all for your attention.
Great, thanks very much, Dr. Yamaleyeva. I think we'll leave you as the presenter in case you need to show any of your slides. We've got a few questions here, and first of all, really interesting work. You know, we haven't seen a whole lot of work on photoacoustics looking at placenta, so this is really sort of groundbreaking stuff. A couple of questions here. The first one is, how does this mouse work relate to the current technology available for human study? So I guess the current clinical practice, what is current clinical practice for measuring things like oxygen saturation or just measuring different elements of preeclampsia?
Well, currently, in clinic, there are some biophysical methods that can measure the oxygenation of the fetus, and that mostly at the late pregnancy when fetal is in distress. And there are no direct methods to look at the oxygen saturation throughout pregnancy, and usually in clinic they use umbilical artery. They look at the flow velocity of the umbilical artery, but that's this is not the direct measure of oxygen saturation.
Okay.
So I think bringing this technology to the clinic would be really exciting and may really help us to establish the mechanisms of some of these complications of pregnancy.
Okay, so yeah, and I guess the work you've done sort of, you know, the translational part, you know, using the, you know, preclinical animal models first before moving into humans. You mentioned some of the limitations. It's just the reason I ask is someone's asked a question here: will photoacoustic imaging replace or complement conventional ultrasound imaging in the clinic? So how do you see photoacoustic in its relation with current clinical practice with regular ultrasound?
Well, it definitely can complement is some of those measurements that are done using the regular Doppler, when you can use, for example, power Doppler, and that's already in clinic currently, and you can look at the vasculature and the blood flow, and if because what the reduced oxygenation is reflected by changes in the blood flow in the placenta. And so I think it could be very complementary to the methods that are already used in clinic.
Okay. Okay. Um, let's see. There's another question here. It's somewhat related, actually. There's a lot of sort of clinical questions coming in. How do you think maternal obesity will affect performing photoacoustic imaging?
Well, that's a very interesting question. Well, we know that obesity is also related to vascular disease in a way. So I guess we also could look at the oxygenation and interestingly that in obesity, the fetus could be could either be with low weight, could be growth restricted, or could have maybe high weight than the otherwise normal pregnancy. So if it's a growth restricted growth restricted fetus, then in this case we could see some placental insufficiency and maybe low oxygenation. So I don't know what's going to happen in the other case, but I think it's a really interesting question, especially with the increase in obesity now in the population, and that many women are obese when they become pregnant. So it's very important to answer that question.
Okay. Okay, great. There's still more questions coming in here. So we've got lots of time, so I'll keep going. There's a question asking, can you distinguish between, and actually this is related to a question I had as well. The question from this person here is, can you distinguish between fetal and maternal blood flow / oxygenation within the placenta? My question, which is somewhat related, is, I mean, how do you, in your imaging that you've done here, how do you distinguish between, maternal versus fetal parts of that placenta?
Well, as I showed, we draw those regions, but basically we based our these regions we distinguish based on the histology. When we look at the histology, we know that approximately this is the fetal and this is the maternal. So definitely this is not, we cannot be 100% sure that some of the areas that are between the fetal and maternal could maybe belong to one or the other. We cannot be 100% sure.
But this is really, I guess, what I'm getting at is,
because of this sensitivity, I can resolution maybe. Yeah.
Yeah, and what I'm getting at is, are you using? It sounds like what you're saying is you're using you're looking at histological images and then comparing those to what you see in the live ultrasound and saying, oh, okay, these structures look similar. This looks related to the fetal part of the placenta versus the maternal part. Is that right?
Right. Yeah.
Okay. Okay.
Because anything we see on the ultrasound, and how do we find the vessels and any pathology or any organ, it all comes from knowing the anatomy, right? So.
Okay.
In this case, also the histology is helpful.
And distinguishing between fetal and maternal blood within the placenta, other than just sort of with the anatomical reference that you have with the high resolution ultrasound images, is there another way to do it? Is it possible that just plain old differences in SO2 or the oxygen saturation will allow you to distinguish the fetal versus maternal parts?
Well, it seems that the fetal part is more oxygenated from what we have done.
Okay. Okay.
from our studies.
Yeah. Yeah. I mean,
So, I mean, that could be some indication of fetal side, yeah.
yeah, we did some experiments here, with on animals where we actually just changed the level of breathed oxygen um, of the mother, and we could see differences in the maternal and fetal side that way. So that was one thing that we've tried here that seems to work fairly well. So it's kind of a neat functional way of seeing those differences. Using the anatomy as a guide, but then using function to do that as well. So yeah, I just wanted to sort of add that note in.
Well, in our study, what I showed at the beginning of the presentation, we see changes, relatively similar changes in the oxygenation when we change from 100% to 20%. I don't know if you go to 5 or 8% oxygen, you may have change in one more than the other side.
Right, right, got it. Yeah, yeah.
Yeah.
Sensitivity to those small changes might not be there. Understood.
Yeah.
Sorry, I'm coming back to that obesity question. There, I think the listeners referring to the depth issue. I guess the depth of penetration issue. So if you have a larger patient, for example, will this technique become more difficult?
Well, at this point, I think the most what I've seen in the literature was the depth of up to 6 centimeters. So definitely, in human, if we are looking at the late pregnancy, this may not be enough, the depth at the current state of the technology. But we know that if we look at the early stages, we may be able to image. But of course, if someone has obesity, then that if you're doing the transabdominal imaging, that may have may represent a problem. It's maybe also possible to use the transvaginal probe.
Okay, yeah, that's an interesting idea.
And that may be helpful in a way, but I don't know if you could see the whole placenta or part of it. So I think it's all need to be tested.
Okay. Well, in your estimation, do you think it's necessary to see the whole placenta, or could you do, some diagnosis just based on part of it?
Well, I think there could be some regions that are more ischemic than the others, and might tell us more about what's going on there. So it's probably better to see the whole, but
okay.
I don't know. At the beginning of the development of this technology, it might not be possible.
Okay. Yeah, because the reason I ask is, I've spoken to other people doing things like, kidney research, and they say, oh, well, the kidney cortex is going to behave more or less the same in a diseased state, aside from something like regional cancer, which could be sort of regional. But in general, if you have a systemic pathology, it's going to affect the whole organ. Therefore, imaging part of the organ should be good enough for getting a diagnosis. I was just trying to, from my limited understanding, I was just trying to see if that applies as well to something like the placenta, or if you need specific, the whole region or just specific regions.
Yeah.
Okay. Let's see. A lot of questions coming in. Let's see. People are pointing out that one listener said fetal hemoglobin holds oxygen better than maternal. So that's kind of an interesting thing too. So looking at these changes over time, maybe varying the breathed oxygen of the mother, you'd see changes faster than you would see occur in the fetus. So maybe that would be another way of seeing the separation between the two. And of course, someone else points out that in the labyrinth you have both circulations, which is certainly true. Let's see. Is poor placental oxygenation associated with lower fetal heartbeat? Could fetal low heartbeat lead to premature delivery? Someone asks.
Well, I think it's it's not that the fetal heart rate, it's probably just the diagnostic method. And so that's why in clinic they're using they can measure also the heart rate itself, and also they can do umbilical artery that reflects the fetal heart rate, and they can certainly diagnose that the fetal distress this way.
Is that something
Yeah.
that you tried? Did you have a look at fetal heart rate and compare it to oxygen saturation?
Well, the problem is that our animals are under anesthesia, and we are trying to keep it constant, the heart rate,
Mm-hmm.
so it between about 380 and 430 or 440
Okay.
beats. And so therefore, in this sort of control condition, because under the same anesthesia, we cannot really tell if there are big changes in the heart rate. I think these will need to be determined in a conscious state.
Yeah, I guess, but the person's referring to the fetal heart rate in this case.
Yeah,
So,
that's what I'm also saying, the
okay,
fetal heart rate, yeah.
okay.
Because
And
it will, mhm,
well, I was just going to say,
it may depend also on the maternal.
yeah, understood. I guess, from my view of your work, I would maybe answer that by saying it's certainly possible to correlate the two. I mean, we with the ultrasound we can get a measure of fetal heart rate through either pulse wave Doppler or even just imaging the heart
Yeah,
and
yeah.
counting, and then also measuring oxygen saturation. So I think those measurements are certainly possible.
I mean, they're certainly possible, yeah. And we also, yeah, we measure also fetal heart rate, yeah.
Okay. Um, let's see. There's a question. What are the major advantages of using the ACE2 knockout compared to other animal models of preeclampsia?
Well, this is not the model of preeclampsia, so we consider it as a model of placental insufficiency,
Okay.
and not preeclampsia, because these animals hypertensive before pregnancy. I mean, their blood pressure is higher compared to control before pregnancy, but not in the hypertensive levels, and it does not increase further during pregnancy. So in this case, we use it because we did see that there was placental hypoxia measured by those hypoxic markers in the ACE2 knockout mice, and we just wanted to confirm this data and to use this other method of photoacoustic imaging and to see if indeed they have lower oxygenation. And for preeclampsia, there are several models that are available. We have a rat model of preeclampsia that we use. We have not used photoacoustic imaging on that model yet, but it's a model with, again, the H2 dependent model, where female rat with overexpression of one of the precursors of the system, angiotensinogen, is mated to the male rat with overexpression of renin, and these females develop preeclampsia, and it's very reproducible. And the advantage of that model of preeclampsia is that we can look at the early pregnancy, because we know which animal is going to develop preeclampsia, so we can look at the early histology and early physiology to try to correlate those changes with some of the markers of preeclampsia.
Okay. There's actually another question related to the different models. They're asking, did you measure oxygenation in mouse models of preeclampsia caused by defective trophoblast migration / placentation?
No, we have not measured yet. We use as I said, this need to be some model that we can look earlier, maybe in the pregnancy. but we have not looked. So it would be interesting to see whether it's will reflect the abnormal trophoblast invasion will reflect the lower oxygen levels in the placenta.
Okay. Okay. You know what? I think we'll leave it there. Dr. Yamaleyeva, I'm really happy that you were able to do this. It's really interesting work. I think there are so much potential, especially for this technology. Being able to do these real-time oxygen saturation measurements and co-registering that with the ultrasound to be able to get at a lot of these issues. And I think the translational aspect, as demonstrated by all of the questions that we've had, those sort of translational questions, is really there, at least in principle, because there is ultrasound used in the clinic for doing some of these kinds of things, as you mentioned, like blood flow measurements and that kind of thing. So thanks so much for presenting this. Just want to remind everyone who's on the webinar that we will be sending this out. A recording of this webinar, we will be sending it out. Please feel free to visit us. Go to our website, www.visualsonics.com. You can submit other questions. If we fail to answer your question here, you can submit questions or request support. You can go to our past webinars at our webinars page. It's visualsonics.com/resource/webinars. Find us on social media channels and visit our booth at conferences. You can see a list of them at our conferences page. And again, if you have any questions about our products or our technology, please feel free to reach out and contact us. And with that, I thank you all for your attention.